today what I'd like to do is teach everybody a new technique which I learned on using a flexible scope to intubate through a King airway. So I don't know how many people have had to deal with it, but King airways are put in by EMS on a not infrequent basis. And the reason they use a King MS, or King airway, is that you have to assume that it was a difficult airway. So what I'd like you to do is just take a look at the features here. So a King airway is designed to go into the esophagus. It is based on the height of the patient and it's color coded, so all you have to do is really look at the chart. But there is a balloon which goes into the esophagus and theoretically is going to occlude it. There is another balloon which goes behind the tongue and gives you access to do some positive pressure. And if you look here, there are a bunch of openings which are over the glottic area, so when you hook up to a circuit, you should be able to oxygenate the patient. So one thing I also want to do is show you what happens with a bougie. If you put a bougie through here, there is actually a port. So you can see that that port is kind of proximal. So theoretically, you can intubate or at least put a scope through that port. It doesn't go through these distal openings, it's only through that port, so keep that in the back of your mind. So what I've got here is a smaller King airway in this patient, and a couple of different things we're going to do. So if you have a person who comes in with this, the temptation is to just take the airway out. The problem is, once again, that it was probably difficult to begin with, so never assume that you are better than the EMS people. The other problem is that this cuff, when it's behind the tongue, actually causes venous engorgement. So even if they weren't difficult before, they may very well be difficult now. So do not take this thing straight out of the patient. Some of the papers that are out there, a significant number of people ended up with a trach, whether they needed it or not. That is the backup plan. So what I've got here is one of our disposable ambu scopes. And if a person were to come in with this, I would consider using this as my technique. So first of all, I'm going to go down there. Now it's a little bit stiff, but if you look at the video, I'll go slowly. Can you see that there is that flange? Talking about this flange right there. What you're trying to do is go above that flange. So I'm going to tip up a little bit. See that hole? That's what you're aiming for. Now I'm going to look at that hole. I do not see anything I recognize. What that tells me is that I'm in the wrong place. So you can't intubate blindly when you don't even know if it's lined up correctly. So what I'm going to do is pull the LMA back, or excuse me, the King airway back until I recognize the anatomy. So right now I am off to the side, but you can clearly see that that is the vocal cords. So if I hadn't done that and I attempted to put anything through there, it's not going to work. So now, bear with me, getting these plastic things through is not 100%. It does work though. It should work. I know it fits through because I've done it, but you do have to grease it up pretty well. And you do not want to get grease on the camera. So you're kind of like a rock in a hard place. But I'm trying to get it to launch over that ramp. And it's being aggravating. All right, so now you see that give? You can expect there to be a give in the plastic. That wasn't me hitting the patient, that was me hitting the plastic. So once you get through that hole, then I'm going to go down just like I normally would to try to intubate a person. And I'm going to try to get down, stay off the wall, which is easier said than done. And I'm going to go down to a nirvana. Okay, so I'm down to the carina. Now, once you're there, what you need to do is get this thing out of here. So I'm going to, if I had to, I could blow oxygen through here if the patient started to desat. So what I'm going to do now is let that cuff down. Never put the cuff up, maybe that's a problem. And I'm going to try to take the King airway out with the scope in place. One thing you have to be very careful with is when you're pulling the king airway out, do not pull the scope out. So I'm looking at the scope inside the trachea as I'm going, because it's really, you lose points if you pull it out. Alright, so now once I get the king airway out, I can grab it safely. And at that point, I can pull the king airway all the way out. Once again, I can blow oxygen in there if I feel like. I'm looking into the trachea, so I'm clearly in there. So at this point, what I need to do is put in a real endotracheal tube. So the one advantage of having a disposable scope is you're going to throw it out. So if you use trauma shears, and make sure you have the correct things, because not everything will cut it, I'm going to go right up here, and I am literally going to cut this nice medium expensive scope. So now what I have is a bougie. So I'm going to take this out. I'm going to take the endotracheal tube, and just like you normally would, you're going to slide an endotracheal tube. Now be careful, they're a little bit shorter. So make sure that somebody gets a good hold of it and you don't pull it out. Now, this was a difficult airway, so the last thing you want to do is just bang it in there without taking a peek. Assumedly, you should have a video available. So what I'm going to do is take the D-blade and I'm going to look and see what my actual airway is. So I can see my scope, and now what I'm going to do is watch it go. If it gets caught, which is not uncommon, remember, you want to counterclockwise screw it gently over the arytenoids. If you do this without watching, you can, but you have to be careful about not pushing it too hard. So difficult airway, take a look with a video laryngoscope, and once it's in there, it's just like anything else. I'm going to pull out the broken scope. I'm going to inflate the cuff, and then I'm going to confirm that I have equal breath sounds. So it's actually not very difficult. The hardest part is getting into the trachea, and that's just a matter of not being afraid to hit that bump, because it's a plastic bump, it's not a patient bump. Make sure it's lined up before you get in there. But it works pretty well. Now, you can also use this to exchange out an LMA, and it doesn't matter what LMA is, you can use it for all of the different ones. So if you chose the wrong LMA, if it's not an intubating LMA, you won't get caught short. You can do this safely. So anyway, watch this video a couple of times, get the feel for it, save me disposable scopes that we can practice this technique with, and give me your feedback. Thank you.